Good afternoon. Thank you for everybody that's prepared to be at 5 o'clock in the afternoon. I was actually expecting not to be anybody, but thank you in any case. So the topic is polycystic ovarian syndrome. People talk about PCOS, PCOS, which is the most commonly used by people. And I think the first thing is what is in a name. And if you go and look at if you look at the poly part means many, cystic means a cyst is literally a sac filled with either fluid, pus or gas. You can get cysts in different places, but I will get back to what people think a cyst is, and polycystic ovarian syndrome is not the same. Ovary, we know it is obviously what it is, and then the syndrome is important to understand. A syndrome is a group of symptoms and signs where medical fraternity have put together and call it a disease or a condition or whatever. So a syndrome, unlike, for instance, you would go for coronavirus where you will be able to be swabbed, they will go look under the microscope, find traces of the virus and be able to then to say you're infected or not. A syndrome is different. If you look at history, for instance, Down syndrome started off as a syndrome. They said if you've got slanted eyes, single folds, certain heart disease, bowel defects, that child is deemed to be Down syndrome. Today, it is actually wrong to call it a syndrome because we can take blood and we can test the chromosomes. It's actually supposed to be called trisomy 21. So that's the difference. So a syndrome is actually a man-made condition. And I will get back to that just now to understand. So that's the first thing which I think is important, is to understand where the name comes from. Now, PCOS is important because it will, roughly about 10% of the population of women will have PCOS. And it is associated with what we would call hyperandrogenism, meaning increase in male hormone, and anovulation, meaning people don't ovulate on a regular basis. So that's basically the basis of the condition, is that it's a condition of not ovulating with increased male hormone. And it's important to understand it is an endocrinopathy. It is a hormonal disturbance. And obviously we talked about the syndrome before, where this group of symptoms and signs we would then put together. There's no diagnostic test. You can't just take blood and say this person has got PCOS. Also, there's no genetic test. We know that there is a genetic link to the condition, and about 20% of women with PCOS will have either a mother or a sister who's got the condition. But it is complex, the genetics. So you can't, people take a swab and come back and say you've got PCOS. It is not available as such at this point. Now, I'm very into evidence-based medicine, meaning looking at science as the basis of what we are doing. Now, this international guidelines was published about 18 months ago in 2018. And how that came about is they firstly had experts from all over the world, which was run by Monash University, and they then put together guidelines. But also they had different societies, meaning the South African Society, SASOC, had a group which was run by Prof. Zephanie van der Spy, which was also on the international panel, and they had then a meeting with some of us. I was also part of it, which also discussed it from a South African, and we also gave input. So this is where this is coming from, and obviously the management of polycystic ovarian syndrome should be based on this, I believe. This should be the basis of where we are coming from, because this is reasonable current medical science. Now, so patients with PCOS, they would have psychological impact of the disease. So the body image issues, meaning they struggle with the weight frequently. They've got hirsutism. But also they've got issues around reproduction, meaning they've got the menstrual disturbances. the increase in male hormone with increase in facial hair, and obviously the infertility, which a lot of us then are interested. But one must understand, it also have got metabolic features. So PCOS is a condition of life. And if you look at this slide, basically this shows us when a woman is young, the big issues is around the periods, the increased male hormone, contraceptual issues, sexual health, and infertility. But as the woman gets older, the metabolic issues of PCOS becomes important, meaning the glucose intolerance, insulin resistance with increase in diabetes, but also cardiovascular disease, and also they can also have an increased risk for cancer due to the chronic anovulation, meaning that they've got unopposed estrogen for long periods of time. Now, if you look at the context, it is difficult because the diagnosis and treatment, although we've got sort of a consensus agreement, there's still controversy. So it's still a problem. The other thing is that there's heterogeneity, meaning PCOS patients don't look the same. You know, when I was a student, there was a picture in a book, and it was called Stein-Leuven syndrome. And at that point, the idea was it was a patient who was overweight, had a beard, acne, and that was the classical look of the PCOS patient. But not everybody looks the same. The other problem is that there's a delay in diagnosis frequently, but there's also overdiagnosis because people don't use the diagnostic criteria. And in studies where they looked at patients with PCOS, they're invariably dissatisfied with the way that they are managed. So we need to do better. Now, if we look at the pathogenesis, I'm not going to go too in detail, but you, on the one hand, have a genetic predisposition, meaning what we talked about, there is definite genetic predisposition, but also lifestyle issues. So basically what will happen is that might lead to insulin resistance, that might lead to obesity. And two things happen. You get an increase in the male hormone, androgens, and also increase in insulin. And that leads to an insulin resistance, and that leads to, obviously, ovaries that's not ovulating. So the increased male hormone inside the ovary recruits more follicles. And what one must understand, and that's where the name of a cyst or cystic syndrome is wrong, because this is not cysts, this is actually follicles. So a woman with PCOS has got a lot of follicles, but because of the mechanism of ovulation being impaired, those follicles don't mature and get to ovulation. So that, which is called cyst, is actually a lot of follicles. And if you do the AMH on PCOS women, the anti-malarial hormone, they've got a high ovarian reserve, and it's frequently very high. So that is with the consequence then of having the increase in hair growth, the hirsutism, acne, the anovulation, meaning that they're not ovulating, but also then the cardiovascular risk factors in the long run. So basically, if we look at that, the lifestyle part is also important. So you can have a patient with a predisposition with PCOS, which might be able to manage it by looking, not being overweight, exercising, and things like that. So that's looking at that. You can't change your genetics, but you can change your lifestyle. What is the symptoms? So there's various things. There's obviously the increased hair growth, which we spoke about. People tend to struggle to lose weight. They can have ovarian cyst, which I said is obviously not right. Low sex drive. They've got menstrual problems, high testosterone levels, the insulin resistance, acne, and obviously then infertility. Now, how do we diagnose it? This is now very technical from a medical point of view. But to make the diagnosis, there's three major criteria. And the three major criteria is, firstly, the polycystic ovaries. Now, since the slide was made, the 12 changed to 20 because we've got better ultrasound machines, so we can count better. So you need to have more than 20 follicles in an ovary, plus then the anovulation, and I will explain to you now how we get to that. And then obviously the increase in male hormone, which can either be symptoms, meaning facial hair, but it can also be in the blood test. Now, to meet the criteria, the cycles need either be shorter than 21 days or longer than 35 days. That would then be regarded as anovulatory cycles. But also important is you get people that have regular cycles which are not ovulating, and in that case we need to obviously confirm the ovulation with further tests. The clinical hyperandrogenism is obviously the increased male hormone. That would be things like acne, increased hair growth, but also hair loss, and in the young girls, obviously severe acne with hirsutism. This is a picture of woman, ultrasound picture. You can clearly see over there all the little follicles there, and there's also new guidelines for automated measurement, where you use a computer to actually count the follicles. And I've got it, and the machine is a lot better than I can ever be. So, but if you use that, you must increase the criteria. So, also important, you get ethnic variation. For instance, Caucasian women tend to obviously be milder. The Middle Eastern women have got very severe hirsutism. African women tend to have more metabolic features and higher BMIs. So also if one look at this from a clinical point of view, one need to take that into account. What I said before, not everybody looks the same. You might think that this is the typical PCOS patient. But when I was preparing a lecture on PCOS a few years ago, Victoria Beckham at some point was the spokesperson for the UK's PCOS Society. So you can also be skinny as Victoria Beckham and still have got PCOS. So not everybody looks the same, so one need to obviously be aware of that. We also need to look at our PCOS patients not only from the point of view of fertility, but also in terms of the long-term consequences of the condition. And we should screen them for either glucose intolerance or for diabetes. The insulin thing is very controversial. Some people are very keen on insulin measurements. The guidelines don't recommend it. The Endocrine Society of the United States don't recommend it. Some people are very keen on doing it, but I don't believe that it really changes your management by doing it. Importantly, is not all patients with high insulins got PCOS. So it means that some people with PCOS is a condition of glucose intolerance, but it is insulin resistance is not PCOS. It's important to understand that. Common misperceptions, as I said, high insulin levels do not meet PCOS. And very importantly is that if the gynae do a scan, see this ovaries that looks polycystic, doesn't mean you've got polycystic ovarian syndrome. You need to have at least one of the other two criteria. And a lot of people have labels put on them to have PCOS which don't have. About 30% of all women with polycystic morphology, meaning the ultrasound criteria that I spoke about, don't have PCOS. Also in young girls, the ultrasound criteria doesn't work because they've got very high antral follicle counts in essence if they're teenagers. So that should not be part of your diagnostic criteria if you want to make the diagnosis in a teenager. Once again, as I said before, there's not at this point a single genetic test that can tell you that you've got PCOS. So that's important. Now the management, obviously, lifestyle is very important. Through a woman's life, frequently we need to deal with the menstrual abnormalities, the increased male hormone we need to do. And then obviously, if they want to fall pregnant, the main problem is that they don't ovulate, so we need to get them to ovulate. And then the other thing is to prevent the long-term complications of the disease, like diabetes and heart disease. Now, lifestyle interventions is been shown to be really important, and that should include diet as well as exercise and behavioral changes. And it's been shown that as little as 5 to 10% have got a major impact on the hormonal picture, meaning that a lot of people by minimal to mild weight loss will start ovulating. So that is very important. and one need to obviously do on an ongoing basis. So the next issue is then, what do we need to do? Now, if we're all aware of what's the flavor of the month, if it's keto, or is it fasting, or is it banting, or paleo, or at some point it was said that the so-called low GI diet was the ideal diet for patients with PCOS. Now, this I took from one of the experts from Australia, he's ex-South African, and on a question about what's the best diet for PCOS, he had this slide, meaning calories count. So basically what it comes down to, what the science says is you need to have a calorie deficient diet, meaning you need to aim for about 30% deficit of what your workout requirements should be per day. And the research have not shown that any diet is superior to the other. Now, what I believe is that not all people are the same. So we need to give people freedom to get to a point where they do something that works for them. So if it is, if you've got a banting diet and you can lose weight to fall pregnant, great. It might not be the greatest thing for the long term, but if that works for you to lose the weight, great. You know, I'm not saying that everybody should do that. So I think that people that claim that this is better or that, you know, or specific programs, there's no scientific proof. But if a certain type of intervention works, obviously that would be recommended for that specific patient. Exercise is very important. About 250 minutes moderate or 150 vigorous, combination of both aerobic but also muscle strengthening. There's a lot of work on not only on PCOS but on weight training being beneficial for weight loss more so than aerobic exercise. So that might be something like that. We need to get people moving. And I talk about the SMART, and that's a specific, measurable, achievable, and time limited. So you need to look at the patient's specifics, maybe to start at 10 minutes if they really can't exercise, and work it up over a period of time to the recommended thing. But once again, the exercise part seems to be very important in terms of the management. We also, if a patient wants to fall pregnant, obviously we need to look at other things like a weight, a blood pressure, look at smoking. We know smoking is quite a negative for falling pregnant. And then we need to check for semen. It is not essential to do tubal patency to look whether the tubes are open if you have a new diagnosis initially. Obviously, if the patient has been trying for a long time, we would definitely do that. But if you've got a new PCOS patient that haven't fallen pregnant, or is obviously not ovulating, you can start to treat the ovulation before the time. Now, very importantly about ovulation induction, we need to have goals, and we need to avoid prolonged treatment. I've seen patients that have been on Clomid for 5 years intermittently. So we need to have realistic goals. And obviously you need to make sure the patient is not pregnant before you start the treatment, because a lot of patients don't menstruate because they don't ovulate. Now, this is now technical, but what I've changed, Clomid used to be first-line treatment, but letrozole, which we all know as Femara, is now the first-line treatment. It seems to be more effective in terms of pregnancy rate, and it also has got a lower risk for multiple pregnancies. But the recommendation is you need to limit it to 6 months, and you need to make sure whether it works. So if a patient is on Femara, also patients are taking it for a year, but nobody have checked whether she's actually ovulating. So you don't have to do it every month, but if you've confirmed that the treatment is working, then obviously that one can use it. The other is the clomiphene, which is Clomid, and the metformin is Glucophage. That we see as second level. The metformin you can also use as a first level, especially in patients that are overweight. But you can use it alone. But one of the big problems which I've seen with metformin or the glucophage is that patients, the diagnosis of PCOS is made and being given metformin and sent on their way. So lots of patients we see a year, 2 years later. So the issue is that it is less effective than Clomid or Femara. So I see it more as an adjunct treatment to the ovulation induction and not as a treatment alone. But if you're going to do it alone, to limit it for about 6 months. Inositol the action is also on insulin, so it's a little bit similar to the metformin, not exactly in the same way. The guidelines actually say that there's not enough evidence to actually recommend it. But in 2019, there was what is called meta-analysis, where people took all the studies together and then came to a conclusion, where it says that inositol alone, or the myo-inositol, or mostly in combination with D-inositol, can be beneficial in terms of either alone in terms of getting patients to ovulate, or as an adjunct to our other treatment. So I've always been adding it, or I think that it's not a bad idea to add it to our treatment, but it is also extra cost. So if your patient must choose either to use the Femara or the inositol, I would think that she should rather go for the Femara. The injections is the second line. Obviously, that's once again technical. That is things like FSH containing preparations or combinations with LH. And that second line, obviously, it is very effective, more effective, but there are issues around that, around cost, but also the fact that it should not be done by people that don't have experience in stimulating patients. Because of the risk, and the risk is looking like this. This is a real picture of 5 babies after gynae F stimulation. This was a disaster. It was fetal reduction was done, and in the end, twins was delivered at 26 weeks. So it's not a really good. Luckily, I'm not the culprit, but this is not a good outcome. So this should not be done in this way. The other is obviously ovarian hyperstimulation syndrome, where people make too many follicles, can have fluid in. With ovulation induction, it's not such a big problem as with IVF, but obviously if you do IVF on PCOS patients, it's a real risk. They are the ones that actually at risk. The other is the laparoscopic surgery, ovarian drilling. That is considered also a second-line treatment. Once again, there's issues around it. It's surgery, it's invasive. And, there's also some people that do it very overzealously, meaning that you actually have damage to the ovary. So one need to obviously be careful when considering the laparoscopic surgery, and one need to consider the risks. IVF is obviously a third-line treatment, or if there's other problems. So obviously if there's a sperm problem of blocked tubes or severe endometriosis, which sometimes can coincide with the PCOS, the IVF would then be the treatment. They always say that PCOS patients make bad eggs. I really don't think that it is necessarily the case. I think that in modern IVF, where we have good freezing, they actually have got a benefit, because the more eggs you make, the more embryos you make, and the more we can freeze. And we talk today about the cumulative pregnancy rate per started cycle, meaning if you've had one stimulation and one aspiration, and you take all your frozen embryos with, how many babies do you make? And I think that in that sense, the PCOS patients, in my opinion, and my experience, are actually at benefit if you do IVF, because they tend to make more eggs, but they've got at risk for hyperstimulation. So frequently we need to freeze the embryos if they obviously hyperstimulate. Then quickly, just about take home, important about correct diagnosis. I think that a lot of patients are either under or overdiagnosis. Understand that this is something that you need to manage throughout your life. Weight loss is important to improve outcome. Exercise is important. Treatment, you need to tailor towards the specific problems. Gonadotropin should only be used by experienced people, and obviously laparoscopic surgery and care must be taken to minimize it. And IVF is then third line. So thank you very much.